Hello, I'm Bill Riley, a member of the team here at Carebridge of Michigan, and I'd like to welcome you all to our latest session focused on sustaining independent primary care. Today, Dr. Jackson and I are joined by Dr. Kurt Lindberg. Thank you, Dr. Lindberg, for joining us today. Before we get rolling, let's take a few seconds, maybe just a sentence or two each, and just have you both introduce yourself quickly. Why don't we start with you, Dr. Jackson?
Well, I've been a primary care physician in family medicine for more years than you can count, close to 40. And I've been helped by being in private practice, I think. I've been able to do it my way, deliver the care that I thought patients deserved. And deliver the highest quality of care, bringing people on for tasks that I didn't want to do, so I could devote my time and energies, my best self, to my patients.
Very good. And we're going to spend a lot of time drilling into all of that in a bit more detail here today. Dr. Lindberg, why don't you give us a quick introduction as well?
Sure. I'm a family physician, full-time family medicine in Holland, Michigan. And I also, as a part-time, am the community physician leader for our network.
Okay, thank you. Bree, if we could go to the next slide. Before we get into the detail of our session today, for anyone who might be new to Carebridge, let's take just a brief minute and give a quick overview. So, Dr. Jackson, can you lead us through this slide, please?
Well, Carebridge of Michigan has a mission to ensure that private primary care practices remain open, remain viable, continuing to deliver the high quality care, cost-effective care that the communities need. And then we are a 501c3 nonprofit. We were founded for the MyPick project initially, and we provided care managers to the primary care practices that needed them, that were involved with that. Instead of closing this, we thought it would be best to continue to serve the primary care community and their patients. And so we've evolved to ensure practice sustainability. A number of primary care physicians who are reaching a point in their life where they want to cut back, or they are thinking about retiring soon, or maybe their practice is just too busy and they want to add another physician. Well, that's a real laborious process. Secondly, it's a costly process, and Carebridge wants to help with that process.
Okay, excellent. So why don't we learn a bit more about Dr. Lindberg and your background. We're talking a little bit before we started our session today about, where we think we might be going isn't always what ends up happening in the end. So
Right.
please give us your story, your path coming out of medical school to where you are today. How did it all start, and maybe what were some of your early expectations?
Yeah, as I reflect back on my career, my path is very similar to the average primary care physician in the US. So I came out of my training with a passion to help people, and specifically in underserved areas. I had a vision of myself as doing everything: nursing home rounds, ICU management, inpatient care, obstetrics. I was doing low risk obstetrics when I came to this community. I thought maybe I'd do Indian Health Service or maybe in a developing country. Very mission oriented. My wife, however, did not have the developing country or Indian health passion, so we settled on the small community of Holland, Michigan, which is beautiful here on the coast of Lake Michigan. But I did start with a full spectrum family medicine, and as the hospital wanted more consistency of presence in the building, they hired hospitalists, so we stepped away from inpatient care As more obstetricians came to town, we stepped away from obstetrical care. The regulations of nursing homes gradually increased to the point where we could no longer make that a part of our practice. And we really now I'm focusing on outpatient primary care. And quite honestly, I feel like this is primary care's superpower. I think what the US healthcare system needs is doctors who are your doctor. And I think patients want that too. They want their own doctor that's on their side and advocating for them. And so it's a relationship, and it's working to develop healthy behaviors and manage chronic disease. And I think that's what primary care's focus and specialty is.
Very good. Can you tell us a little bit about your path? Like you've always been an independent physician, or what has the path been there?
Yeah. So I hope you tell me I look too young, but 1999 is when I started practice. There was very few employed primary care physicians. That was a rare model. If you went to a university health system, maybe you would see that, but primarily if you were going to be a clinical outpatient physician, it was almost all independent. So that wasn't a choice of mine, was independent versus employed at the time. And I know that is a big decision that new trainees entering the workforce need to consider. But for me, one of the things that I was told very early, and again, I was very mission oriented, and still am. So I see my job just not as a job. I see it as a service to people, and that's how I see it. But I was told, don't let yourself get into a work situation that you're going to feel overwhelmed. One of my mentors in medical school was the only working person in his family. So his wife stayed home with his 4+ kids, and he took a half-time position because in his reasoning, he'd have more time with family, and a half-time physician salary is still decent. And so that was a model for me going in, that I wanted to have a lifestyle that allowed me flexibility and time with family and the things I value the most, while I continued to do the things that I love in serving others.
Very good. Very good. Before we move on, I just want to go back to a comment you had made earlier before we started recording here today. We like to talk about how healthcare is local, and
Yeah,
you were sharing some thoughts around the how a physician or medicine will tend to adapt to the needs of a community.
yeah.
And can you talk to that a little bit?
Yeah, there's something in medicine called a stem cell, and these are a cell that isn't defined. So it's not a heart cell, it's not a brain cell, it's not a muscle cell. It can be anything. And a lot of people talk about how primary care and especially family medicine is kind of a stem cell. You enter into the community, and then you become what that community needs. I came into a community that had very little obstetric providers, and it needed more people to take care of low risk obstetrics and have the obstetricians doing the more complicated cases in the C-sections. As the needs evolved, so did my practice. I have primary care doctors that have become focused primarily on female care because that's what their community needs. Some that are doing primarily ADHD management or chronic pain management or things. So primary care can wear a lot of hats. Dr. Jackson probably remembers the quip of jack of all trades and master of none that we were ridiculed with in our training. But I take that as a badge of honor, is that we really can do a little bit of anything.
Excellent, excellent. Thank you.
And an
Okay.
anecdote, when I was in medical school, they told me not to go into family medicine because I was too smart. And then they told me, you can't know everything.
Yeah.
So I figured I must be about right.
Okay, great. So let's talk about, let's move to the next level here, and let's talk about primary care. We want to look at this through two different perspectives. First, let's talk about in terms of patients and care delivery. We'll start there first, and then second, we'll get to what this has meant to both of you in terms of flexibility and freedom. That'll, and you both kind of touched on that. We'll get to that one next. But first, let's just start talking about independent care with respect to the caring for patients. caring for families over time in an independent setting. For our audience here, we're going to have medical students, perhaps people wrapping up their residency that maybe haven't considered independent practice, or at the same time we'll have we always get employed physicians that might be curious, learning more about independent practice. So when it comes to serving patients, caring for patients, let's talk about care in this type of setting. Dr. Jackson, why don't we start with you? What's your view of caring for patients as an independent physician?
Well, I like Dr. Lindbergh's analogy of stem cell, because indeed you do evolve, right? You take care of people where they're at. I had the opportunity to, if I wanted to, change my hours and go see some patients in their homes. I had the ability to, during COVID, right? I decided that we were going to do parking lot testing, and I tested well over 4,000 or 5,000 patients outside, all day long. It didn't matter how hot or cold it was, and as a result, it was fulfilling, because I got to know most of the patients, a lot of the patients in the practice. And I remember one time when we realized steroids would be helpful in reducing the inflammation that occurred with COVID and reducing oxygen levels, that this diabetic would need insulin now. So the pharmacy was slow in getting it, but I was able to meet him outside in our little shed after hours in the dark. So I gave him a shot in the dark. And I was able to, start him on insulin, teach his wife how to do that. And I really wouldn't have had that opportunity if I was an employed doc. I wouldn't have had a place. They would have told me, no, you can't do that. But he was well served. So, and I saw Frank the other day. He's doing well.
Excellent, excellent. So, Dr. Lindbergh, what are your thoughts?
Yeah, I think all of us go into healthcare with the vision that we're going to be advocates for patients, and that the patient is the reason. Taking care of people is what we want to do. I hope that's why we went to medical school. And when you get into an independent practice, you get to steer that ship of that practice and your own career in that direction. And when you start becoming an employed person, now employed hospitals are good and we need them, but at the end of the day, their interest is in self-preservation and their own bottom line. And I guess that maybe is the need. But it also gets in the way of that patient-physician relationship. And Dr. Jackson's story of, we did what we needed to do during COVID. We made patient care the priority. We didn't make money or the bottom line or the success of the program or continuity across the area. I know one of the most frustrating things about hospital administrators is variety of care, because it's hard to control, and you want to assure a certain level of quality. In an independent practice, you get to make those decisions. You get to decide on what you think is best for the patient, and so you don't have someone kind of steering your ship on your behalf.
Very good, very good. Okay, why don't we go to the next topic now, which is more around the freedom and flexibility, autonomy topic. And we've kind of touched on this a little bit already, but let's talk about what this has meant to you, personally in your lives with your families at home. So, Dr. Jackson, can you get us kicked off here?
Yeah, I harken back to when one of my daughters was in middle school, and she had a big issue. Now, luckily, I practice and live in the same community, which is nice. But my wife was out of town, and she needed me. So I just told the staff, I'm leaving, I'll be back. I went and got some things for her at home, brought them to the school, and things were good. I felt like a dad. I was able to make her and my other daughters track meets, every single home track meet, because I could rearrange my schedule. There, I can't say there weren't challenges, but some of these little things were really important to me, and I think that helped.
Great. Dr. Lindberg?
I would echo Dr. Jackson's perspective that, life is more than work. We talk a lot about the quality of our work situation, and I think having an independent practice makes work more enjoyable. But life happens in your home more, and having that ability to flex and overlap, and make choices. We not infrequently at my independent primary care office make decisions. Are we willing to take a lower salary to make this decision that will improve our quality of life? We have hired, for instance, somebody who fills out forms for us, and it's one of the things that doctors hate the most is filling out, FMLA forms or disability forms or things like that, and just to have a hired staff to take that work off your load so you can go back in and see the next patient and get home on time. That's a lifestyle choice we made, and we get to make those choices every day in independent practice.
Very good. Very good. Okay. So for our next topic here, for each one of these sessions, we try to take up a subtopic and drill into a bit more detail. And for our session here today, we'd like to talk in a bit more detail about this idea of succession planning and the importance, if we have a practice with physicians at or nearing retirement age, the importance of planning ahead. So Dr. Jackson, maybe you can get us kicked off with this topic, and then Dr. Lindberg, I know you're kind of right in the middle of this right now,
Yeah.
so you can share your perspective. So Dr. Jackson, why don't you take it away?
Yeah, my practice consists of 3 offices, and my office has 6 physicians. I just retired, and I couldn't leave my community without a place to go. So, my sister is in my practice as well, and she's not that much younger than me. So we hired a doctor, and then we hired another doctor. This is how I realized this was not an easy thing, right? But I felt so comforted by being able to retire, right? That knowing that my patients were in good hands. And I've heard from some of them, they walk by my house and say, I'm seeing Dr. So-and-so, and I really like him, right? So that's comforting as well. My concern was that I knew a number of physicians over the years who just closed shop. Nobody took over the practice. A number of physicians who sold their practice to a hospital, and then I would see their patients, right? Their patients were coming to my office because they didn't like the new setting. Dr. Jones couldn't be Dr. Jones there. That's what their feeling was. And so I realized there was a role for sustaining these practices, and somebody had to do it, right? Secondly, I know from reading, because I'm medical director of a physician organization like Dr. Lindberg, that primary care physicians in private practice are cost effective. We can refer to patients where we want, right? We can refer to the most cost-effective specialist, the highest quality specialist, and they don't have to be in a particular health system. They can be outside of a health system, maybe that we are engaged in, so that cost effectiveness is really important for communities. We know that the cost of healthcare is going up and up and up, and the quality in private practice physicians is comparable to slightly better on average nationally in private practice. So I think there's a couple good reasons for doing that.
Very good. Thank you. So when we talk about succession planning and this idea of getting a new physician into a practice, this does not happen overnight. So we want to talk about this in a bit more detail. Dr. Lindberg, as I mentioned, you're kind of in the middle of this right now. So
Yeah.
can you share some of your thoughts about this scenario?
Yeah, we were, so I'm part of a group that's about 10 doctors all in one office, all family medicine. And when I came to the practice, the people who started the practice were still there. One of them still is working. And we have all stayed around. And if one person, moved out of town or retired, we just, we decided to let people know we're looking, and someone applied and we filled it immediately. So, but times have changed. The reimbursement to family medicine has not kept up with the costs of running a practice or with the value that we bring. There's a reason this is a harder decision to make now. And hospital systems are paying more than a primary care independent doctor can pay. And so for us to be able to hire a new graduate, they look at what they can get at a hospital system and what they can get at my office, and they make that choice very frequently to go with the higher salary. So we've talked a lot about how we think, Dr. Jackson and I think that the lifestyle offsets that difference. You still get paid, to the example of my mentor who took a half-time position and still had enough money to raise a family. He chose a lifestyle over a salary, but you have to find the right person who's willing to do that. And you have to help them understand that value equation. It's not everybody coming out of training that's willing to do that. So you do have to kind of start early. You have to explain that value, make sure they understand that value, and help. And then you mentioned on the slide right now, you talk about non-compete considerations. There are a good number of people that make that decision, get into it a year or two, and pretty soon sour on the whole idea of working for a health system because of the lifestyle issues we've just been talking about. You don't get to drive your own boat. You don't be able to make patient care your priority. You're beholden to the health of the system you've signed on to. But now you have a non-compete. There's a lot of debate over whether you can enforce one, but no one wants to risk their career on getting sued. So people get stuck. And if you have your kids in a school system, you don't want to move 50 miles away to get out of your radius that you are restricted to. So that's a big problem that we're running into right now, is people that would love to come out of a network setting back into independent, but they're finding some barriers to that.
Very good. Very good. Great insight for those listening in that, might be, approaching this situation. So thanks both of you. Okay, as we start to wrap up here today, let me do just a quick commercial for Carebridge. We are in the process of recruiting prospective practices that may have these kinds of needs, succession planning and beyond. So whether you're an individual practice with these needs, or perhaps you're part of a physician organization and you've got member practices that may be approaching transitions, or the flip side of, maybe you're a currently employed physician and you're curious or interested about making a change and perhaps joining an independent practice. We'd love to hear from you. The final slide here gives our contact information. And like I say, call, email, we'd be delighted to hear from you. Okay, so that wraps us up for today. First,
Dr. Jackson, you had your...
Yeah, there's it's not all lower salaries, right? There are choices you can make that make your life better too. Like I said, I'm recently retired. Well, our 401k had 100% match. that means I could put more away for my retirement, twice as much as you can at a hospital. And that's an important thing to think about as you, because you always have to think about your future self. The building I'm in right now is partly owned by me, right? So we rent from ourselves. We had to rent from somebody. So I might as well put it into equity that I have. So it's not all that bad economically, because
No,
I have some of these
agreed.
benefits as well.
Yeah, what we have had, all of our physicians in my practice have remained for their whole careers, and so that says something. They found it valuable. Yeah.
Okay, very good. Well, gentlemen, thanks again. And for our
Thank you.
audience, thanks for joining us, and please enjoy the rest of your day.